Ataxic disorders begin with impaired coordination due to dysfunction of the cerebellum and its connections, including spinocerebellar and frontopontocerebellar pathways. Patients present with gait imbalance, scanning speech, nystagmus, limb incoordination, and intention tremor. Clinical differentiation begins with cerebellar, vestibular, and sensory ataxia. Cerebellar ataxia causes pure imbalance without vertigo, while vestibular ataxia produces vertigo and illusory motion. Sensory ataxia results from proprioceptive loss and worsens with eye closure. A positive Romberg sign confirms reliance on visual input for balance. Time course guides diagnosis. Acute onset suggests toxic, vascular, or infectious causes. Subacute progression suggests immune, metabolic, or paraneoplastic etiologies. Chronic progression suggests genetic or degenerative disease. Acute symmetric ataxia is commonly toxic or metabolic, including alcohol intoxication, phenytoin toxicity, lithium exposure, and inhalational toxins like toluene. Heavy metals and chemotherapy can also contribute. Subacute ataxia develops over weeks to months. Key causes include vitamin B1 and B12 deficiency, alcohol-related cerebellar degeneration, and paraneoplastic syndromes linked to breast, lung, or lymphoma cancers. Autoimmune ataxias include anti-GAD65 and gluten-related ataxia. Infectious causes include prion disease, especially iatrogenic variants in rare settings. Chronic ataxia is most often genetic. Hereditary spinocerebellar ataxias, hypothyroidism, neurosyphilis, and chronic metabolic disorders must be considered. Focal cerebellar ataxia often results from vascular lesions like cerebellar infarction or hemorrhage. Tumors, abscesses, and multiple sclerosis are important alternative causes. Inherited ataxias show autosomal dominant, recessive, or mitochondrial inheritance patterns. They may involve cerebellum, brainstem, spinal cord, peripheral nerves, and sometimes cognition. Autosomal dominant ataxias include spinocerebellar ataxias caused by repeat expansions such as CAG. Pathogenesis includes protein aggregation, transcriptional dysfunction, and neuronal apoptosis. SCA1 presents with progressive cerebellar ataxia, dysarthria, nystagmus, and possible extrapyramidal features. It is caused by ataxin, gene CAG expansion with anticipation across generations. SCA3, or Machado-Joseph disease, is the most common spinocerebellar ataxia worldwide. It combines cerebellar ataxia, Parkinsonism, dystonia, and peripheral neuropathy. Friedreich's ataxia is the most common autosomal recessive ataxia. It presents before age 25 with ataxia, areflexia, cardiomyopathy, diabetes, and scoliosis due to frataxin deficiency. Ataxia telangiectasia presents in childhood with cerebellar ataxia, telangiectasias, immunodeficiency, and increased malignancy risk due to ATM gene mutation and defective DNA repair. Treatment of ataxia focuses on identifying reversible causes such as tumors, autoimmune disease, vitamin deficiencies, infections, and metabolic disorders before labeling degenerative disease. Vitamin E deficiency, thyroid disorders, and gluten-related ataxia are treatable causes. Management includes supplementation, dietary modification, and treating underlying systemic disease. Genetic ataxias have no definitive cure, but symptomatic treatment and rehabilitation improve quality of life. Episodic ataxia may respond to acetazolamide. The key clinical takeaway is to always search for reversible causes first before labeling ataxia as degenerative or genetic, as early treatment can significantly alter outcomes.